So, good evening. I'd like to welcome everyone to tonight's Journal Club meeting. My name is Dr. Ravin Patel. I'll be serving as the club advisor, moderating tonight's Journal Club meeting. I'm originally from Cherry Hill, New Jersey, did my undergrad med school in Fort Lauderdale, fellowship at Penn State University. I'm now working in private practice orthopedics in the suburbs of New Jersey. So the goal of the AMSSM Journal Club is to provide a national platform for student and resident members to present an article from the list of the top 120 that every sports medicine fellow should be familiar with list. Our intent is to make this a fun learning experience to give medical students and residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. The format for this journal club is that each presenter will have approximately a 20-minute block of time that includes a brief Q&A segment after their presentation. So if you guys have any questions, just enter them into the chat function during the Q&A, and I'll call on you when I'll have you ask the question to the presenter. So with that, I'm pleased to introduce our first presenters of the evening, Dr. Josh Schulte and his club mentor, Dr. Jaclyn McKenna. Dr. Western family medicine. His interests are in sports medicine. They specifically align with diagnostic ultrasound, guided procedures, metabolic health optimization. He grew up in Iowa with two brothers and played Division III football. Now that football, his primary activity is rock climbing. His presentations on the article Endocrine Profiles in 693 Elite Athletes in the Post-Competition Setting. I'd also like to thank Dr. Jaclyn McKenna for serving as his club mentor. Dr. Jaclyn McKenna is intending internal medicine. She's board certified in internal medicine with a certificate of added qualification in sports medicine. She currently serves as head team physician for the Westchester Knicks of the NBA G League, and she's an avid beach volleyball player. So, Dr. Schulte, if you want to take it over.
So, yeah, my name is Dr. Schulte. I worked with Dr. McKenna, and then the journal that the article that we're presenting is the Endocrine Profiles in 693 Elite Athletes in the Post-Competition Setting. It was in the Clinical Endocrinology Journal in 2014. The primary author was ML Healy. So kind of as we start, this will be kind of a standard journal like review sort of style. We'll start broad and then kind of end with the discussion. And hopefully we'll be on the shorter end rather than the longer end. This article was, again, like I said, in the Clinical Endocrinology Journal in 2014. It was a pretty standard cross-sectional cohort study. So they took those 693 athletes all at one time. It was a 2-hour post competition phase. They drew blood, and that was the extent of the collection. The purpose that they stated was to kind of normalize post-competition endocrine profiles in elite athletes and kind of have a database of endocrine markers. And then with that, they could inform on doping and overtraining / metabolic issues during or for elite athletes. And then one of them that they didn't really state, but then they kind of comment on in the end is using it for the Olympic Committee in determining like if somebody was male, female, transgender sort of profile. The study design, again, observational cross-study or cross-sectional cohort. So they simply drew the labs and then made some data analysis. The population inclusion criteria was they had to be an elite athlete, which meant that they had to compete on either the national or international level in sports. And there were lots of different sports that they collected from. And then this cohort was actually a subgroup of another study that was going on that was called the GH2000. And so they pulled from that group to create a subgroup. The exclusion criteria was basically that they drew a lot of the serums long before they actually analyzed the data. And so when they went back to analyze the data and try to normalize some of this stuff, they lost a lot of the data files, or the serum was either not enough or it wasn't, they weren't able to run the studies on them. So they went from an initial 813 that screened down to the 693. And then you see that 450 of them 454 were men, 239 were women. And again, because it was an observational cross-sectional study, they didn't have a control group and they didn't have an intervention. So a little bit more on the study design. Let me see if I can move my, there we go. They collected baseline demographics from all of the participants. So that's gender, age, weight, lean body mass, which they used one of those tools where you kind of have the skin and then it gives you a reading for lean body mass. It wasn't like in a pool or anything. They used fat mass, height, BMI, which was just calculated, and then they listed their sport. And then they drew blood, and this was collected 2 hours after a competition, which again, it had to be on either the international or national level in order to call them elite athletes. So 2 hours after competition in an elite competition phase. They analyzed 19 biomarkers from the blood, which I listed all of them here. It's not necessarily as important to like know exactly which ones they did, but some of the more common ones that obviously most of us know about are growth hormone, insulin growth factor. Some of these more esoteric ones were used as kind of downstream markers for some of the other ones. So a lot of these listed on the left here correspond to growth hormone cascades. And then the ones on kind of the right and including the luteinizing hormone are the ones that, most of us are pretty familiar with. So FSH and TSH with the like active components, estradiol, cortisone, testosterone. I put this, chart that I'm sure some of us love and some of us hate here on the right, just so we can kind of remember that some of them that they tested are hypothalamic and they go down into the pituitary, where you have most, in this one, they didn't collect any of the posterior, but the anterior lobe hormones. So you see GH here, you see thyroid stimulating, and then obviously, as we remember, those kind of cascade further down. They have either the thyroid hormone, testosterone, estrogen, and then I don't have it here in this chart, but if we remember, a lot of these will then feed back to the pituitary. So like, testosterone will feed back and turn off the hormones when it's elevated, which will come into play here in towards the end of the slides. So let me make sure, there we go. The outcomes and statistical analysis that they listed, they were kind of going for the mean. So it's really important to realize that most of what they studied was the mean hormonal differences. So it's not individual, but they used mean data for gender and sport, and then they correlated the hormones between those groups. So whether it was gender or whether it was sport, and then they also used those physical traits as well to create some analysis. They used lots of different techniques of statistical analysis. I listed them here just to show which one's which. So if somebody wanted to like go back and look at them, they're all kind of listed here. But then to kind of describe what some of them are, just as a reminder for us, the arithmetic mean versus a geometric mean is typically used in some of that demographic information. So height and, and weight. And then they also use the geometric mean for testosterone. So just to kind of help us, because I also didn't really understand what they meant, the arithmetic mean is simply the mean that we, most of us know. It's calculating, like adding all of the variables on the top and then dividing by the number of variables, which gives you a certain curve. But for example, and I'll show you the graph, in testosterone, the curve was skewed. And so they used a geometric mean, which is basically, instead of adding the variables, they multiply them and then do the square root of the number of variables, which just gives you a little bit better standard deviation when you have either a skew or outliers, which they had in some of their data. And then down here on the right, again, just for reminder's sake, as a lot of us are now clinicians and don't, sit around and think about this too much anymore. Some of the things that they used were like a t-test, which is quantitative data versus qualitative. So, a number and then another number they use to create a t-test, or a linear regression, which again, they use that. And then, so that would be, more like the hormones that they measured. And then chi-square would be when you have a qualitative. So that would be, again, more like the demographic or like the BMI sort of things. Actually, not BMI, it'd be more like categorical. So moving on to the findings, some of their key findings, and I have a couple slides of findings. One of the main ones that they commented on and they wanted to find was, were there any differences between the genders? And they did find significant differences between 19 of the 24 variables. And again, it's important to remember that these are the means. So they found significant difference in the means of the variables between men and women. However, there was, and I quoted it just to make sure that we're all on the same page, there was considerable overlap. And one of the examples is testosterone, which I have here on the right. So the top is male measures for testosterone, and the bottom is the female. And you can see that most of the female are in this normal, quote unquote, normal range of 0 to 3 nanometers, which I think is like multiply by about 25, and that's what you would get probably in like a hospital setting. So like typically we see a male testosterone in like the several hundred. So you just have to multiply this. But we can see that the male means are going to be in this range, and then the female are way at the bottom. But you also have female outliers that are way up here in the upper limits of the male. And from their data, they reported that they do not think that all of these females were, they think that one of them was on anabolic steroids, but the rest of them were not. And I kind of touch on it here a little bit later on as well. And then they also commented that they think these male testosterones that are low, there was a good chance that they had central hypothalamic hypogonadism. Some of the correlational observations that they made, which again, this was just, they think it, and I'll touch on it, but they think it was one of the first times that it's been reported, like endocrine profiles was reported. And so it's, it might kind of seem very intuitive, but for them, making these correlations was important. But if a female had higher testosterone, they typically were taller, thinner, had lower estradiol and higher thyroid, which again makes sense when we look at our cascades and our HPA axis. And then the growth hormone, which again, in that last slide, all those other factors that were on the left, they kind of correlate as well, like you would anticipate they would. Here's just a slide that has way too much information, but I was just showing, this is kind of these are the markers they were measuring with growth hormone. And really the important part is I wanted to like kind of list some of them that they measured, just to show that when you get growth hormone, they expect some of these insulin growth like factor, the ALS, to go up, and then they would expect some of them to go down, which they saw. So they were just commenting that they saw what they expected. And then some of the sport specific trends, again, fairly predictable, but it was important to list them. Things like basketball players were typically taller on average. Weightlifters were typically heavier on average. The older you were, the more likely you were to be in certain sports. And then some of the outliers, and we kind of touched on this already, they really only had concern for one participant being on steroids. And so that would then mean that there are lots of outliers. And so the individual data doesn't necessarily correlate or correspond with the means always. And then on the right here, I just put again, as kind of a reminder and just like a tangential idea that when you use exogenous steroids, you would expect there to be this negative feedback on the hypothalamus and the anterior pituitary, which would then suppress these like growth hormone releasing, the LH, the FSH, and the endogenous testosterone. So when they said that the person they thought was using steroids, it's because that person had an extremely low LH and had a really high testosterone, where all of the other outliers had what they would consider fairly normal levels of LH for the level of testosterone that they had. So some of the clinical relevance, the data supports individual variability over the generalization, which I've kind of touched on this, and I think is more or less an important point from this, that there is useful data using the means. It kind of gives you this standard, what you would expect to see most of the time, but there's also this very big individual variability. So to, use just the means to interpret a single participant or single athlete's results would be fairly hard. One of the ways, though, that it could be useful is something like relative energy deficiency syndrome. They've got decreased intake, and then you see changes in their hormones, and you could compare that then to the means to kind of prove yourself right, or like kind of rule it in and give you insight into whether this specific athlete maybe is actually having that versus something else going on. And then the other point that they mentioned in their paper is the potential basis for an athlete's biological passport. So using it not only for health, but also for, is this person all of a sudden having this massive jump in testosterone? And maybe that gives you some insight into the fact that they could be doping. Moving into their discussion, again, it was a very interesting way that they kind of used a large part of their discussion to kind of talk about the male and female normalizations. And then they commented on, and this again was in 2014, but the Olympic Committee used testosterone levels to determine male versus female. And so they used this data to show that, yeah, there's a standard mean, but because of the outliers, it doesn't necessarily correspond to what you would then call male versus female. However, when you used lean body mass and compared it to testosterone, it was actually much better at predicting male versus female. And this is kind of the scatter plot that shows that. But again, I wanted to kind of point out, like you can see here, this gray dot, that's female, gray dot is female, and they're in the kind of male lean body mass plot. But again, on average, you do see that there is kind of a corresponding male versus female. And that was one of the things that we wanted to touch on, and why I have the picture here. But there was a lot of discussion about the transgender participation in the Olympics. And so could this data therefore help and aid in the future use in determining, who does or who can or can't compete? Yeah, there's probably some, support for that. But also, can you use something as simple as testosterone? Probably not. There probably isn't enough evidence, regardless of, kind of whatever other, input people want to make into those decisions. So the strengths of this study, again, they were stating that they think it's the first large-scale endocrine study on elite athletes. And it did have a fairly large sample size when you use the conglomerate. And most of them were presumed to have a minimal doping influence, or at least they don't suspect that many of them were doping. The limitations, unfortunately, in a cross-sectional study, I think there's always going to be a lot of limitations. And so, one, not having a control group, it's being post-exercise. If you wanted to extrapolate sports, then you kind of have small sample sizes. And for the most part, besides really the testosterone, they don't report raw data. So it's really hard to know anything besides the means. And then, although they can use this to kind of catch more or less the more standard ideas of blood doping, so take testosterone or anabolics, there's kind of this new renaissance of using peptides, which I'll touch on here in a second, but it seems like this probably wouldn't help a ton with that. So then the application to kind of us as sports medicine folk is, the clinical implications are that we now do have, fairly normalized endocrine data for elite athletes. And again, it's important to know that these are a different population than just like a general, weekend warrior probably. And that gives us insight into their hormonal responses post-competition. It can guide strategies for both whether you want to train them, rest them, how nutrition plays a role on endocrine profiles. And like we touched on a little bit too, it gives us this idea of overtraining and hormonal imbalance. And so this is, again, where the REDS, or the relative energy deficiency, comes in. And I put a picture here to kind of show what you would expect to see in that. So when you have in the center here this kind of low energy availability, you can kind of follow this down and you'll see that you would have low LH, you'd have low FSH, you'd have low testosterone or estradiol, which then you could use to kind of, if you calculated this on your, or if you collected this on your athlete, you could then relate it back to these norms and be like, okay, this person is, 3 standard deviations below the normal, like they probably have something going on. So it's very useful in that sense. The limitations for our practice, again, obviously, it's hard to reiterate, but the cross-sectional design of it it limits it very much in whether it's cause and effect conclusions. If one is high, does that mean that this person's other hormones should be high or shouldn't be high? Not having the raw data and the individual data makes it a little bit hard to create cause and effect. And then the variability between individuals and sports, again, is a big limiting factor when you want to apply this to a certain individual when it comes to, training or what have you, when it relating performance between certain athletes. One of the limitations that I was talking about a little bit was the peptides. I just put this in here straight out of a paper's conclusion. They basically were writing about how they use their methods to test for doping agents. And so I thought it was kind of interesting to read through how they do it and where their limitations are. And so I highlighted what I thought was the most important part, especially for peptides, which then is a limitation from the study. But when you have these small molecules, it's really hard for them to analyze them. And this section here that's highlighted is basically showing that the peptides act quick, they're very short lifetimes, low concentrations, they mimic hormonal responses naturally. And so it's very hard to catch them, even though they are currently trying. And then the picture on the right is showing that athletes are almost always ahead of the game. So you see an athlete uses something, and then they don't get caught for several years after they can figure out how to test for it. So you see, again, somebody used an agent and then they figured out how to test for it later. And so I just think that it's kind of this, if you're really trying to catch people doping, unfortunately, it's always going to be a little bit hard because they're going to be willing to do things that haven't been done before. And then the last kind of section here, recommendations, future research, obviously having longitudinal studies to track changes over time, to track individuals over time, to track trends or changes within the groups that they already studied. And then having both the recovery and seeing how that impacts the endocrine profiles, but also having the endocrine profiles and seeing how that impacts performance. Because unfortunately, it's really hard, especially from a study like the one that we're going over, taking just raw endocrine data and then extrapolating that to performance, which is ultimately what a lot of athletes want. That's what they're interested in, is how do they perform better? And I think that future research will help kind of inform that. So in conclusion, again, we have a foundation, we have endocrine profiles with means that kind of normalizes both male, female, and then certain sports. And that gives us a generalizable male female norm and average, but it doesn't really give us too much in the way of individuals because there's just so much variability. And so, recommendations would just be to use the individual profiles, track them over time. And when you need to, you can then kind of revert back to this kind of normalized mean data. And then obviously, for the people who are interested in the doping world, they would have to kind of really work on the biological passports and being able to determine an individual athlete's changes over time, and they could use this data then to inform on that. So here's some questions that if people are interested in, or we can have other discussion questions.
Awesome. Thank you, Dr. Schulte, for your presentation. I wanted to give this club mentor, Dr. McKenna, an opportunity to share any additional comments about the article or subject matter in general.
Hey, sure. So I mean, Dr. Schulte did a really nice job summarizing that. That was a lot of data in that study. He went for explaining all the biochem and biostats too, so that was awesome. But I just kind of want to echo his point that this was like a really simple study. But without having a study like this, we're like really in the dark. Like, as much as it would be great to have more athletes, college athletes, different timing trends, like they were able to collect so much data, and like the clinical applications that you hit on, not only on like performance enhancing drugs, maybe clinically evaluating people who are like REDS category, and then like really interesting how this was a 2014 paper. And I did like I was in fellowship 2 years ago, and I had a presentation on transgender athletes, and there was later review articles like 2020, 2021, where they're talking about like testosterone levels, and like they're looking back onto this paper. That was kind of like the initial way to really appreciate the outliers, like especially in those female athletes, and how like at the end of this paper, they basically said it would be unethical to exclude any woman from sport based on a testosterone level, but they didn't even use the word transgender, you know? So like, just interesting how like 10 years have passed, and, or 11 years, you know, and how much has changed in sport. But then, I mean, yeah, those are the big things. There was a lot of extra charts in the paper that they basically like tried to do correlation coefficients with every single data point, but it didn't really add much to the paper in terms of the conclusions. The big takeaways were like the testosterone levels and the trends. They did hint on the fact that muscle mass, or like lean body mass alone, is probably the driver to like performance in sports. So there's been later studies where they've seen, like, if you're just looking at like time sports or a weightlifting sport, where endurance sports, you'll see like a 10-15% performance difference between men and women, and like the weightlifting sports, it's like pushing more like 30%. But that when they look at lean body mass corrected for weight, it's about those percentage ranges. So like, and even in transgender athletes, when they're correct, like their testosterone either is suppressed or supplemented, you're never going to be able to like overcome those lean body mass numbers to achieve like a perfect, fair, you know, like to normalize the effects of gender completely. So that was all done later, but yeah, that's all I have. I'm open to any questions. Great job, Dr. Schulte.
Awesome. So I think we do have a few questions in the chat. I guess a two-part question. First is, why were the basketball players taller? Do they have any baseline labs from several years ago that they were comparing?
I can take that. So yeah, I guess the first one was a joke. But the second one, so these were all the athletes got their labs checked at one time point. They weren't rechecked at any point.
Gotcha. And then I think that's just kind of the basis of the study, where it's like this is a good launching point for future studies and just establishing baselines as well. But obviously we can revisit more questions if they come in. But one, pleased to introduce our second presenter, Grace Kugler, and her club mentor, Dr. Robert Dimeff, who's also the primary author of the article that she's presenting. So Grace is a second-year med student at the University of Nebraska Medical Center. She first became interested in sports medicine as a lifelong athlete and majored in athletic training at the University of Nebraska-Lincoln. In her free time, she loves to read, exercise, play with her dog, Maple, and work PRN as an athletic trainer in Omaha. She would like to thank Dr. Dimeff for serving as her mentor for the iron and the athlete. I'd also like to thank Dr. Robert Dimeff for serving as her club mentor. Dr. Dimeff has specialized in primary care sports medicine, non-op orthopedics, and regenerative medicine at Texas Orthopedic Associates in Dallas since 2018. From 2009 to 2018, he was the director of primary care sports medicine at the University of Texas Southwestern Medical Center in Dallas, where he was a professor of orthopedic surgery, pediatrics, and family and community medicine. He's team physician for the NHL Rock and Roll Half Marathon from 2011 to 2018, and head team physician for UT Dallas from 2013 to 2018. So with that, Just want to hand it over to Grace and let her get started.
So today I'm going to be presenting over the review article, Iron in the Athlete. One of the primary authors, Dr. Dimeff, is also my mentor for today. And this was published in the Current Sports Medicine Reports in August 2005. And so it's kind of crazy to think that it's been, almost 20 years since this was published, but it's a really good summary and synthesis of different considerations for iron status in athletes and a good guide for what physicians should know and be thinking about. And so today I'm just going to be following along kind of the flow of the article and maybe adding some context to a few of the key points that are brought up. Before I get into the article, I really want to emphasize why we care about iron status for athletes. And so we know that iron deficiency anemia is the most common form of anemia in athletes, and it's also the most common form of anemia worldwide. And in terms of both health and athletic performance, it really is important to be aware of iron deficiency, understand why it occurs, and how to treat it. And this quote here is just from a recent JAMA study that was showing how high the prevalence of iron deficiency is, and getting into iron deficiency anemia as well. And this is just a small sample, 12 to 21-year-old females, just to provide some context on why this is important. We're going to start with going into some of the background, a little bit of the biochemistry, not too much. And so iron is present in blood as hemoglobin and in muscle as myoglobin. In this role, it functions to transport oxygen. It's also an important component of the electron transport chain. It acts in the cytochromes where it helps with redox reactions. And this leads to kind of an interesting theory about why you may have some of the symptoms in iron deficiency anemia that exist that could be related to maybe inefficient ATP production with low iron. Iron is also found in transferrin, which is the transport molecule for iron, and it's stored in ferritin, which is inside of the reticuloendothelial cells, which are primarily found in the spleen and bone marrow and a little bit in the liver. And any deficiency of iron, heme, or globin can cause produced red blood cells to be low in their or altered in their hemoglobin content. And this is why we have so many different forms of anemia, for example, the thalassemias or sickle cell anemia or things like that, not just iron deficiency anemia. How do we get iron in our diet? Well, there's two main forms, heme and non-heme. Heme iron is found in meat and is considered more bioavailable, whereas non-heme iron is found in plants, and it's still an important source, although it's estimated that if you were to consume only non-heme iron, you would require 1.8 times the amount of intake to have that same level of absorption in the gut. And different people will have different requirements estimated for iron intake. This will vary based on age, sex, or personal characteristics such as pregnancy. In general, the population that we're most often dealing with, we would be looking at anywhere from 8 to 15 milligrams per day for the RDA. And in general, when we say that vegetarians may be more at risk of iron deficiency, this is due to that slightly lower bioavailability of plant iron. However, there is good evidence to suggest that well-planned vegetarian diets are perfectly sufficient for athletic performance, although you may want to consider referring to a sports dietitian who can help make sure their diet is complete and well-rounded. Next, we're going to talk about some laboratory testing that we would be looking at for iron deficiency and iron deficiency anemia. And we're going to start with that CBC and DIF, which is our workhorse for anemia. And I'm sure you all have seen this many times, but I'm just going to go through this just for completeness sake. And so iron deficiency, and this is a key point that I will come back to again and again, but it occurs across a spectrum. And so you won't see alterations in red blood cells on the CBC until very late in iron deficiency. And that will present as a microcytic anemia, which means it would have a low MCV and a low mean corpuscular hemoglobin, or MCH. You also might see a low reticulocyte index or count. The reticulocytes are the red blood cell precursors, and so those will be low as well when you don't have enough hemoglobin to be putting into those blood cells. This is in contrast to other forms of anemia. For example, if you're concerned about B12 or folate levels, you would be looking for a megaloblastic anemia, which is a macrocytic anemia, so you'd have that high MCV looking at that. And then you also have your normocytic anemias, which have that normal MCV. And for those, you would maybe be considering hemolytic anemia, for instance, and there would be more lab values to go along with that. So just to summarize, early iron deficiency, you won't see too many changes on the CBC, but you'll see that late and it'll be a microcytic anemia. So next, we'll go through some of the other measures for iron. And our next big test here is going to be serum ferritin, so testing those storage levels. That will most likely be the first to drop with an iron deficiency. However, we know that ferritin is an acute phase reactant, and so it can vary due to infection, inflammation, or other causes. And so it might not always be the most reliable if you have maybe multiple pathological processes going on in your athlete. It also has showed to maybe vary in relation to exercise due to things like changes in blood concentration and minor inflammatory-like reactions. And so it's useful, but it may not always be our most accurate test. So other things we might want to look at include TIBC, which is kind of measuring how much capacity there is for iron binding, as well as our transferrin saturation. So seeing how much of the transferrin is truly carrying iron. And then finally, talk briefly about the soluble transferrin receptor concentration. And so this marker is considered to have much less variation than serum ferritin and considered a more reliable marker. What it is it's a receptor in hematopoietic cells that takes up iron from transferrin, and it would be elevated in iron deficiency anemia, but not, for instance, in anemia of chronic disease, which would be one where our ferritin levels would not be where we would anticipate. And there's been some good studies to show that STFR can detect subclinical iron deficiency in adolescents. And it's not used very often. I think it's used probably more often in hematology and oncology, for example, but it is a reasonable additional test if your labs are vague and you really want that number to kind of confirm your suspicion of iron deficiency. Next, we're going to talk about true anemia. And before we can do that, we need to talk about this sports anemia, which is essentially a pseudoanemia. And so this occurs when you have an increase in aerobic exercise or intensity, things like that, where you're having cardiometabolic adaptations. And the goal of that is to increase your blood volume, essentially, so that you can have increased oxygen transport. Well, in this situation with adaptations in the kidneys and the RAS system, your plasma volume will increase before red blood cell production will catch up. And so this is a positive adaptation. It allows you to have greater reserve of fluid, intravascular volume, especially with the dehydration in sports, but it can cause that dilution, which may show up as, for instance, an abnormally low hematocrit or something like that on your labs. And so this is just something to think about. It will self-resolve and does not need to be treated. Next, we'll talk about some things that lead to true iron deficiency anemia. And so common causes, we know iron deficiency anemia is very common, and common causes include poor intake or restricted diets, blood losses, either GI or menstrual. And so I briefly want to touch on this gastrointestinal blood loss. When we exercise, obviously blood is shunted away from the viscera to the muscles for the purpose of exercising, and this is theorized to lead to a transient ischemia in the gut, where you would get a pseudomucosal injury or insult, and this would cause kind of small occult blood losses in watershed areas where maybe you're at most risk of having low blood flow in that area. Menstrual loss is pretty self-explanatory. This would be especially high risk for athletes who have really heavy periods monthly. And then there's iron loss and sweat, and then there's also foot strike hemolysis and thermohemolysis. And I will touch briefly on those in a second because those I was not as familiar with when going into this presentation. Foot strike hemolysis is essentially when you have the breakdown of red blood cells due to repeated contact between the foot and the ground in those small capillaries, and that lyses the cell contents. And then thermohemolysis is essentially when your temperature elevates, and we know from biochemistry that when temperature elevates, the lipid membrane becomes less stable, and so this can also destroy the red blood cells. And there's varying reports in the literature about how much either of these contribute to iron losses in athletes, but they're well-known phenomena. So as I've mentioned before, iron deficiency occurs on a spectrum. And it's important to note that our athletes are more sensitive to iron deficiency anemia because of their high demand of oxygen delivery and utilization, and they need that efficient oxygen delivery to exercise and just for daily living. And so some signs and symptoms you may see would be exertional fatigue, tachycardia, palpitations, headache, nausea, vomiting, poor concentration, and poor sleep. The problem is that these are all really vague symptoms, and we know that our athletes have a lot going on in their lives, a lot, at the high school or college level, they have academics going on. There's, stressors from daily life, maybe poor diets, less sleep, things like that. And so even with all the things going on, and this is a point I'm going to come back to, it's just important to have a high index of suspicion for iron deficiency, so that way you can test for it if you're concerned. You might be wondering if iron deficiency is such a common problem, especially in athletes, are we regularly screening for it? The answer is no, although it probably depends on you personally where you're practicing. Screening, obviously, it looks for a diagnosis of someone who is not symptomatic, otherwise we'd be considering it a diagnostic test. And so screening, there's really no universal guidelines for iron deficiency screening in athletes. For example, the NCAA doesn't have any screening guidelines, even for female athletes who are cross-country runners at a D1 level. But often screening does occur in individual institutions and programs, depending on the team physician's discretion. And so there's also variability in diagnostic criteria and treatment protocols to go along with that. And I found, doing some research that even the professional society that is writing the guidelines might have different opinions. The key thing I think to think about for screening is that not only can it catch low iron, it can also catch elevated iron. And I've spent a lot of this presentation talking specifically about iron deficiency, but elevated iron also is a problem. The boards like to hammer in hemochromatosis, so that's what I have the pictures of on the slide. But I think maybe even more relevant to athletics would be, using a CBC or iron screening to detect excessive iron intake or potential blood doping or steroid use, for example, because steroid use will elevate your red blood cell count. And that's dangerous because that can lead to clotting issues. And so screening is important not only for too much, but also too little iron and vice versa. You might say, okay, how should we treat the iron deficiency anemia? And I would say first, it's important to consider the concept of food first. And so we want to be encouraging a proper diet with variety, and we want to be getting all our vitamins and minerals from food first. However, in general, you will be prescribing iron supplementation for a lot of these athletes. And in general, it's important to think about that vitamin C can increase iron absorption from vegetable sources, and that can be especially important in your vegetarian and vegan athletes. Variety of foods can improve iron stores like fortified grains, red meat, dark poultry, seafood, eggs, beans, and lentils, etc. Iron can be supplemented oral or IV. IV obviously would be saved for really serious deficiencies. In recent years, I think there's been some controversy on how to dose the oral iron supplementation, maybe every day versus every other day. This is due to the thought that high doses of iron every day would cause downregulation of iron absorption in the gut, and then you wouldn't even be getting all of the iron that you're supplementing. The problem with that is compliance, and so it's hard to remember to take a medicine every other day compared to every day. And then, so if you're forgetting, then you're getting even less iron than you would be maybe even with some downregulation. And so that can kind of change with the discretion of the physician who's prescribing that. In female athletes with heavy menstrual periods, it's also important to consider potential hormonal contraceptive to help reduce monthly bleeding and prevent iron loss that way. And I'll also mention here, if your female athletes are not having menstrual periods, that doesn't mean, oh, great, they're not at risk of anemia. You know, there could be other issues going on, such as red S. So that's just something to think about as well. And then finally, when we talk about supplementing iron, we want to consider the principle of do no harm. And so it's important not to over supplement iron. And, you know, there may be patients who are taking iron prophylactically without evidence of deficiency. And the review article mentions that indiscriminate iron supplementation carries the risk of inducing hemochromatosis, individuals especially who have the allele variation for the HFE gene. And so that's something to think about as well. And when you're dosing the iron, ideally this supplementation would occur in the short term, and then you would be following up with labs on your athletes as well. So the take-home message from this review, in my opinion, is to have a high index of suspicion for iron deficiency anemia. We know it's common. We know the different mechanisms that exist for iron loss, and we know that it can occur in a spectrum, and that deficiency will happen a while before, at least 120 days before true anemia, because the life cycle of the red blood cell is 120 days. And so it's important to have a high index of suspicion. And then if you're not sure about your labs, get creative with the testing. So if your CBC and your ferritin are normal, but you're still having a concern, you can look at other things like the TIBC, the percent saturation, and potentially an STFR if you want to make sure you have the laboratory data to support that diagnosis. And that's all I have. Thank you.
Thank you, Grace. I like your last point, especially about keeping a high index of suspicion, because it is so common and it can present. So before moderating the Q&A, I wanted to give our club mentor, Dr. Dimeff, an opportunity to share any additional comments about the article or topic.
All right, so Joan called me and made sure that my video is on, so hopefully you can see me. I can only see a black screen right now.
That's perfect for us.
You're good, Dr. Dimeff. We can see you.
Okay, fair enough. So no, I think Grace did a great job. It's hard to believe she's a second-year medical student. I mean, that covered the topic extremely well, pointed out, I think, what I think are the salient features. There was one question in the chat about, is iron deficiency anemia more common than pseudoanemia? You think, you know, from an athletic standpoint, I don't know that anybody's really done that study specifically to look at that, but if you think about general population, pseudoanemia is going to be only occurring in your high-level aerobic athletes for the most part, so it's going to be much less common. So you think about that when you're dealing with your athletic population. I think she covered the topic extremely well. I don't have a lot of criticisms by any means, and I think I would open up for chat. I mean, I don't know that there's a whole lot to clarify. She did a phenomenal job. And she applied the science to the clinician. She's like a clinician as a second-year medical student. Oh.
Yeah, I'd have to echo that. I was very impressed. I had to double check that she's a med student. I think she was able to articulate the topic very well compared to what I could at this point. Another question, what level do you from? Is there a certain level or threshold?
Yeah, you broke up. I suspect I know what you were going to ask. Is that like what the ferritin level is shooting for? Yeah. I think, you know, this is one of these things that clinically we've been talking about for years. And personally, I shoot for a level of 40. Steve Simon, I saw, is on the chat. I'd be curious what Steve shoots for in his aerobic athletes. But, you know, part of the issue is, depending on when you check the level, you know, they may be dropping. So if they're at 40 and then all of a sudden you get down to 25 or so, you may not be aware of it. So I tend to shoot for a level of 40. And I've seen anecdotally many cases of people with athletes with these, you know, vague symptoms that Grace pointed out. And it's like they get their ferritin levels 12. It's like, okay, well, that's still in the normal range. Their CBC looks normal. Their indices are normal. And you supplement them, and all of a sudden those symptoms resolve. And it's like, okay, well, is it cause and effect? And they stop the iron, their symptoms come back. So I think we've all seen this sort of anecdotally in our high-level athletes with low ferritin levels that that they have a whole variety of symptoms. And so my goal is 40. You know, she mentioned hemochromatosis. I've been practicing a couple years, as most of you know. I've seen one case of hemochromatosis in my career. So.
Okay, so 40 is a good threshold if you're not sure, depending on the call, like what to shoot for. That's like, I agree with that number as well. But yeah, again, great.
Hey, Bob. Since you pointed out that I was not stealth enough on this, first of all, again, Grace, that was a fantastic presentation for MS2. I never would have guessed that had I not seen that in advance. And Bob, your number of 40 is seemingly very reasonable and one I would like to shoot. My coaches are all insistent on 50 these days. And they're always arguing that I want this number at this level because I don't want them to drop during their season. It's difficult to pin down an exact number, and then just be insistent that we're not going to supplement them in the event that the coach thinks that they might need it. I will point out, and Grace alluded to this, that treating a specific ferritin can be challenging because of those, depends on the timing on the blood draw. And if in fact, if it was post exercise, if there was a subtle, we tend to check our Notre Dame athletes several times during the year, and they always get a check in December. Well, there's a rampant viral illnesses at that time. And so now we're running our ferritins up, perhaps falsely. And so I'm always cautioning the coaches to get hung up on a single ferritin number. And just as a practical matter, again, a very nice presentation, Grace.
Thank you.
Yeah, Steve, you brought up a point I mentioned as well in terms of recognizing, and Grace said this as well, ferritin is an acute phase reactant. So I picked up a number of malignancies in people with high ferritin levels. So if the level's high and it doesn't make sense, you have to start kind of looking at that. So anyway, and what he said is exactly true. In the winter months, all these viral infections, acute phase reactants, and you have to have a high index suspicion and be a good, primary care sports physician.
And Bob, like between you and I, we're probably in the 70 to 80 years of experience. And I also have had only one case of hemochromatosis.
Of course, it's a board question.
Yeah.
All right. Well, thanks, everybody. Appreciate the invitation, and Grace, phenomenal job.
Thank you.
Awesome. So we'll just keep moving on to our third and final presenter of the evening. Please introduce Dr. Logan McCall and his club mentor, Dr. Austin Gillette. Dr. Logan McCall is a second-year family medicine resident at West Virginia University Wheeling Hospital. Originally from Dundas, Canada, Dr. McCall's pursuit of medicine began to found passion for the well-being of collegiate athletes and researching injury prevention in baseball. His co-residents will attest that when he's not volunteering at local high school sporting events, he's glued to the screen, enthusiastically watching the live stream of his little brother's hockey games. His presentation is on the article Attention Deficit Hyperactivity Disorder and the Athlete. I'd also want to thank his club mentor, Dr. Austin Gillette. He's a board-certified family and sports medicine physician, works at Baptist Primary Care in Florida, family medicine residency and primary care sports medicine fellowship at the University of Florida. His interests within sports medicine include youth sports coverage, sports specialization, joint injections, and teaching medical students the benefits of both family and sports medicine knowledge. Dr. Gillette currently serves as a team physician for Mandarin High School in Jacksonville, Florida. Outside of medicine, he has a strong interest in astronomy, even going as far as completing an honors thesis studying exoplanets in the Milky Way. So, Dr. McCall, if you want to.
Hi, my name's Logan McCall, and I'd just like to start by thanking my advisor, Dr. Gillette. He's been a great help throughout this process today. So I'm here to talk about the paper, Attention Deficit Hyperactivity Disorder and the Athlete. It's a 2011 AMSSM position statement paper. So it's going to be formatted a little bit different than some of the other papers that we've talked about today. So with this presentation, I'm hoping to provide you with some improved understanding in the signs and symptoms of ADHD, generalized knowledge of medication used in the treatment of ADHD and the impacts that it has on athletes, both beneficially and detrimentally, as well as highlight the importance of staying up to date with the athletes' regulatory bodies. So the purpose of this paper was to review previously published literature and practice parameters to offer position of the core issues related to the athlete with ADHD. The paper accumulated the current literature into ADHD in the athlete and published an overarching opinion of the AMSSM and their recommended approach. However, this article, as you can see, was published in 2011, and it was recently readdressed in May of 2023. So today we're going to be focusing primarily on the 2011 paper. However, I'm going to highlight some of the changes and adaptations that have occurred between 2011 and the new revision. However, really, I do recommend that anyone takes the time to read that 2023 paper. It's a great read. So ADHD is a disorder affecting somewhere between 4 to 10% of American children. While some symptoms diminish with age, 65 to 85% of children diagnosed with ADHD will still meet diagnostic criteria as adults. ADHD is a behavior disorder defined by chronic impairing behavior patterns that result in abnormal levels of attention, hyperactivity, or their combination. It's characterized by inability to regulate attention and concentrate at a normal developmental level. Although the DSM-5 states that symptoms often present before the age of 7, many compensatory mechanisms and learned behaviors in childhood can delay diagnosis until adolescence, adulthood, high school, college, or beyond. Team physicians should be aware of the resources available for their athletes and understand the core symptoms of ADHD, which may also often be perceived as laziness, lack of personal responsibility, or oppositional behavior. While the team physician is important in identification of the diagnosis of ADHD, they're equally as important in providing a perspective to coaches, family, and others regarding the symptoms of ADHD and their impact on the individual. So on screen now is the table from the 2011 article depicting the classical traits pertinent to the athlete with ADHD in the absence of treatment. Things like poor attention span, difficulty initiating or completing tasks that find boring, lack of organizational skill. But at the bottom, they also comment on the behavior features of ADHD, which can include low frustration tolerance, increased mood lability, dysphoria, poor self-esteem, and academic difficulties as a whole. Where here we'll see the updated position statement emphasized using the current DSM-5 diagnostic criteria. The diagnosis is made with the input of standardized self-reporting scales or checklists completed by parents, teachers, coaches across multiple contexts, whether that be at home, at school, work, or in sport. Critically, these scales can also reflect the perceptions and the attitudes of those completing them towards the athlete or student. These changes in the current updated DSM-5 highlight the differences in the diagnosis between childhood and late adolescence or adulthood, as well as emphasizing the differentiation between symptoms of predominantly hyperactive as well as predominantly inattentive type ADHD. Neuropsychiatric testing can be considered as a useful tool to assist with the diagnosis and may be helpful with developing personalized cognitive behavioral therapy. However, a disadvantage of neuropsychiatric testing is that the setting often removes the individual, the patient, from any distractions or executive functioning impairments, which in turn impact the results of their pattern of performance from that neuropsychiatric evaluation. Neuroimaging and laboratory evaluations are rarely necessary for the diagnosis of ADHD, especially when no other etiologies are being considered. Now, taking a holistic approach to patients with ADHD, the 2011 paper emphasizes the effect of ADHD on sports participation. Studies have shown that gross motor skills are frequently impaired in patients with ADHD, that stimulant used during exercise can lead to higher core temperatures and heart rates without an awareness of the increased effort by the participant. Patients with ADHD perform poorly and less effectively in motor regulation than their neurotypical peers. Gait abnormalities resulting from attempts to improve the base of support, such as exaggerating out-towing and increased step rate, can certainly influence comfort when it comes to physical activity. And athletes with ADHD are more likely to have low levels of physical literacy, which may impact their actual physical performance. However, more research into this area is needed to determine how the low physical literacy directly affects attention and impulsivity. Overall, a lack of cohesive understanding of what, if any, influence an ADHD diagnosis has on sports participation rates presents a worthwhile investigation opportunity. Now, the optimum treatment or management approach to ADHD is one that's individualized. It involves behavioral therapies and consideration of medications. While there's strong evidence to support the use of several medications to effectively treat ADHD, psychological interventions such as counseling, behavioral, or cognitive therapy can be very useful in managing the associated features and comorbid diagnoses in ADHD individuals. Overall, the combined treatment of behavioral management with stimulant medication represents the gold standard of ADHD treatment. This was emphasized both in the 2011 article as well as in the 2023 revision, where the authors increased their strength of recommendation regarding combined pharmaceutical and cognitive/social therapy to recommendation level A. So looking into the role of exercise in ADHD treatment, exercise has been shown to improve ADHD symptomatology. There's little potential harm in recommending continued physical activity in athletes with ADHD. There's insufficient evidence for or against exercise as a treatment of ADHD. However, subjective symptoms of ADHD and comorbid mood disorders can certainly improve with exercise. There's also some evidence that exercise enhances the effects of stimulant medications, leading to a greater benefit for the individual. More research is definitely needed to demonstrate whether the prevalence of ADHD is overrepresented in athletes because of the attention activating effects of physical activity, or because those with ADHD gravitate towards pursuits that require more attention activation, sort of like chicken and the egg situation. Studies have shown that 30 minutes of continuous moderate aerobic physical activity is showing significant improvement in reaction time as well as cognitive tasks, suggesting improved attention. It also shows that 30 minutes of intermittent exercise has been shown to improve the ability to control their impulsivities as well as increase attention for tasks. While combined psychotherapy and stimulant medication is the gold standard of treatment, many alternative treatment plans are used for individualized reasons. Common alternative pharmaceutical treatments include atomoxetine, clonidine, and guanfacine, and bupropion. So some of the benefits of these medications are that they typically do not require any therapeutic use exemption for approval. The downside is that many of them take a longer time to achieve therapeutic effects over periods of weeks, and they may not be as effective at symptom control. Additionally, each of them has their own individualized side effects, such as clonidine and guanfacine's impact on hypotension and bradycardia and QT prolongation. As mentioned earlier, treatment includes medications such as amphetamines, dextroamphetamine salts, methylphenidates in both instant release and extended formulations. It's currently recommended that long-acting medications be prescribed initially due to their lower abuse potential. The monitoring of athletes with ADHD should be individualized. It allows for the ability to track behavior as well as comorbidities, the latter of which may allow team members to modify management accordingly. The frequency of monitoring is, again, individualized and determined based off of the initial clinical interview. It's also determined off of what the individual needs. Monitoring young athletes receiving medication and stimulants to treat ADHD or growth deviation is significantly important, as the appetite suppressant side effect of these medications can impact weight gain, height, and we should be watching for any significant deviations in their expected growth and development curve. Upon initiation of the treatment, it's important to note how medications impact their ability to exercise and perform. A medication is best initiated in a time of low stress, such as a practice or preseason camp, versus the high stress of game situation. The decision to use these medications during sport versus only for academic and behavioral reasons is one that should be made on a case-by-case situation. All athletes with ADHD are likely to benefit from some general behavioral and skill-oriented treatment, including time management, organizational skills, stress management, and problem-solving skills training. Emphasized in both the 2011 and the 2023 papers is the value of treatment and how untreated ADHD has cascading impact on the individual. There's been increase in prevalence of anxiety, depression, bipolar, oppositional defiant disorder, other mental health disorders as well when patients with ADHD go untreated. Cognitive and social development can also be hindered when you do not treat ADHD, which can be a barrier to participation in sport. Those with ADHD that are not treated will have a higher level of social rejection and rejection sensitivity, which then means that they feel that they're unwelcome within sports. Treatment lowers the risk of substance abuse and dangerous driving and academic underperformance, and most significant, impaired peers relationship. Now, when addressing some of the more common complications of treatment, the big one is sudden cardiac death. Now, sudden cardiac death in athletes is a concern, has been reported in those that use stimulant to manage their ADHD. It's currently believed that stimulant use does not increase the risk of sudden cardiac death in patients without any underlying cardiovascular disease. Otherwise, stimulant use in athletes has no significant difference between the sudden cardiac death rates within the general public. However, dextroamphetamines and amphetamine salts, they do carry a warning for cardiovascular events and sudden cardiac death with misuse and overuse, so taking them as prescribed is important. Routine EKG before initiating stimulant medications has shown no benefit to preventing any sudden cardiac death events. The 2023 revision increased their strength of recommendation in this regard from level C to B. Additionally, there may be an increased risk of heat injury in athletes taking medications for ADHD while exercising in hot environments. The evidence suggests that an increased risk of heat injury may exist with medications such as methylphenidate and bupropion and modafinil, while there's some evidence that suggests that the athletes taking stimulant medications have elevated core temperatures while exercising. An increased incidence of exertional heat injury or heat stroke has not been demonstrated in these populations. Next, a common concern with prescribing stimulants is the risk of abuse. The fear of potential abuse in prescribing stimulants or other recreational drugs is not justified to withhold pharmacological treatment of ADHD. Taking a stimulant medication does not increase the risk of abusing the stimulant or other recreational drugs. In fact, treating ADHD actually reduces the risk that the individual is going to have subsequent substance abuse. The AMSSM emphasizes the importance of not withholding treatment for ADHD due to this concern, with a strength of recommendation A. And lastly, the ergogenic effect of medications used to treat ADHD is unclear, as these medications are often used and misused for this reason. Studies have shown an improvement in variables associated with success in sport, such as accelerations, time to exhaustion, reaction time, but the evidence suggesting that the competitive performance benefits of a stimulant used in athletes is limited. Unfortunately, many conclusions have been based from subjective reports, hypothetical extrapolations, limited research designs, and other non-valid protocols. But furthermore, studies assessing performance effects may be biased in that most of them were not conducted exclusively on patients with ADHD. While additional quality investigations are needed to confirm performance enhancement claims, knowledge that there are potential ergogenic benefits was changed from a strength recommendation level C to that of level A with that 2023 revision. Now, team physicians should be aware of and educate their athlete on regulations and requirements with pharmacological treatment of ADHD. Athletes with ADHD can participate at every level. However, many governing bodies do not allow for the use of stimulant medications without formal exemption. For example, the World Anti-Doping Agency, or WADA, requires that athletes taking medically necessary banned substances under physician supervision, such as stimulants for ADHD, have a therapeutic use exemption approved before competition. The therapeutic use exemption approval is for a new diagnosis or medication can be granted for 1 year. If the medication and dose remain constant, subsequent therapeutic use exemptions may be granted for longer period of times. Any change in the medication or the dosage requires resubmission of that therapeutic use exemption, which is why sometimes individuals will prefer a non-stimulant medication. And all this information and the requirements and regulations are subject to change year to year. And any medical professional that is working with athletes with ADHD and that may require World Anti-Doping Agency approval should be very knowledgeable of their situation. Other medications that are prohibited by the World Anti-Doping Agency can be found on their website link that is here in this slide. It also has a checklist for the therapeutic use exemption of medication used to treat ADHD on their website. The NCAA allows the use of stimulant medications with the submission and approval of their ADHD specific medical reporting form. Documentation required by the NCAA includes the following of a description of the evaluation process, a statement of the diagnosis, including that it was confirmed, a history of ADHD treatment and what medications they've tried before, a statement that a non-banned ADHD medication has been considered. This does not mean that it has to have been attempted, but only that it has been considered prescribing. And lastly, that there's a statement regarding follow-up and monitoring visits. These documents and the results of the annual participation evaluation are required to be updated yearly to ensure the eligibility of the athlete within an event of a positive test. The student athlete should be updating their school and their team physician with any kind of medication changes or new medications started. The institution is obligated to maintain a medical file with a record of the clinical evaluation to provide to the NCAA in the event of a positive test. Wonderfully, the AMSSM actually has on their website under the members content in the patient section forms for the NCAA medical exemption form for ADHD. which is extremely helpful for anyone that is going to find themselves in that situation and requiring the proper documentation. Now, the one thing that the 2023 revision included was this table that covered the other professional regulatory bodies. And just for the sake of time, some notable new topics from the 2023 revision included a comment in looking into children of marginalized communities diagnosed with ADHD and how they are less likely to be to use their prescribed medication. They have a higher dropout rate from treatment. Some of the hypotheses that are explaining these disparity include the access to healthcare, the cost of medication or healthcare. There's communication and language barriers, and the fact that a known diagnosis of ADHD does carry some stigma and negative views. They also approach the impact of ADHD and concussion. They commented that the likelihood of concussion is 1.6 times to 2 times more common in individuals with ADHD compared to their neurotypical peers. Dependent on age, there seems to be a lower incidence of concussions when comparing medicated to non-medicated peers. The individualized decision to continue or adjust ADHD medication dose should be made after post-concussive evaluation and should be monitored for both their efficacy and worsening adverse side effects after experiencing a concussion. Lastly, another major component of the 2023 revision was the inappropriate diagnosis of ADHD. There are various medical conditions that can mimic the signs and symptoms of ADHD, and appropriate diagnosis and treatment of ADHD is paramount, particularly when we're talking about athletes, because of the extensive exemptions and monitoring that's required, as well as the risks that are placed on these athletes if they are to be taking stimulants and competing. The AMSSM is advocating for a multidisciplinary approach when it comes to the diagnosis and treatment with specific expertise for adequate clinical management. And with that, I thank you for listening to my presentation on the 2011 AMSSM position statement on ADHD in the athlete.
Excellent. Thank you for that. You covered early. Just wanted to give Dr. Gillette an opportunity to share any additional comments that he had.
Yeah, I think the biggest thing I took from this review of ADHD is, one, really important that we don't miss the diagnosis of ADHD on not just athletes, but whether that's our pediatric patients in the general health community or even adults, actually, because as Dr. McCall so eloquently put it, we see that there are problems with like substance abuse in the general population if they're not appropriately treated. But also for athletes, there's actually a lot of decent evidence saying their athletic performance can suffer as well. So really important that we don't miss the diagnosis and then we treat appropriately. And the other thing I was thinking about while I was talking too is a lot of times for all of us who are taking care of maybe pediatric patients for ADHD, we always kind of defer to the two settings that the Vanderbilt scores or other scores to evaluate ADHD tends to be kind of school and home. But when you think about it, you can actually utilize a sports team or an academic or athletic team the patient is a part of as another setting. So we can also get a coach's opinion to see, is that person focusing as well as they could be? Do they seem attentive, or is there signs of ADHD? And that can be the second setting, whether or not we use school, home, or something else. So I thought that was just something that was worth highlighting.
Yeah, absolutely. And just a question quickly about this is, what are the negative ramifications with lack of treatment for ADHD? I know you touched on it a little bit.
Yeah, so one of those negative ramifications is essentially that we often think about the academic aspects of ADHD and the ability to control inattention and hyperimpulsivity, but we also have been learning more about the psychological impact when it comes to the anxiety, depression, rejection sensitivity, and how that impacts their social development. Essentially, when treating kids, I think that we can use these medications for assistance in developing these cognitive, behavioral, and social skills so that as they progress into teenage years, they're not impacted in their peer relationships, which then leads to not wanting to participate in sport because they're feeling rejected, they're feeling left out.
Excellent. Well, thank you so much. I just wanted to thank all three of our presenters for tonight, Dr. Josh Schulte, Grace Kugler, outstanding send a special shout out to Dr. Jaclyn McKenna for serving as a club mentor for Dr. Josh Schulte. It was amazing to have Dr. Robert Dimeff share his insights in the article that Grace Kugler presented as the primary author of the article, and for serving as a club mentor for Grace. And finally, Dr. Austin Gillette for serving as a club mentor for Dr. Logan McCall. I'd like to also thank everyone who attended tonight's AMSSM Journal Club meeting. It was my pleasure to serve as the club and the Journal Club will be held on Monday, January 27th from 8 to 9 Eastern. I hope you'll make plans to join us, and this concludes tonight's meeting. Thank you, guys.